Okay, we're just 2 minutes past. I think we're going to go ahead and get started. Thank you so much for everyone attending today. Happy holidays to everyone. I hope everyone enjoys a nice break, much needed. Today we have Emily Fessler, who is project manager for Healthier Mo, and we are going to continue our conversation on practice transformation today and looking at how we're transforming public health services, especially in Missouri. So I'll let Emily start her screen share, and thank you so much today for joining us.
Okay, hopefully you guys can all see this, and thank you so much. I'm really excited to be here and to have the opportunity to present to you guys about this. Public health is definitely in the news a lot lately. I think we all know that. And so it's a very timely topic to be talking about ways that we can do systems transformation work. So as Cass said, I am the project manager for Healthier Missouri. And so I'll go ahead and get started. But if you guys have questions as we go, just drop them in the chat and there will be some time and opportunity at the end to kind of go over those. Okay, so many of you guys might be familiar with the Healthier Missouri initiative, but some of you guys may not be following your conversations you guys had last month. But during the past year and a half, we've continued to do our work, but because of COVID-19, we've really scaled back our direct interaction with LPHAs and other system stakeholders, as we didn't really want to add to their workload. They've obviously been really overburdened, as much of the healthcare system has been as well. So therefore, I just kind of want to bring everybody up to speed about, where we've come from, where we are, and where we're going with this initiative. And then I'll kind of wrap up by sharing some ways that you guys can be engaged with the effort. And then, of course, I'll answer questions at the end. So public health has been under attack for a while, especially with COVID-19, but threats around public health have been occurring even before that. So a lot of the main threats include infrastructure erosion, lack of standards on public health services, variations in the capacity to provide foundational public health services, and to what quality. Problematic silos are a major issue, the lack of political support and funding cuts. Missouri actually spends the least on public health than any other state. A lot of these threats then have impacts on the public health workforce and then have detrimental impacts on the communities in which public health is really the only services provided. The difficult part in advocating for public health or justifying infrastructure capacity building is that when public health is working, the public doesn't really know that it's there. So usually leaders and politicians prefer to invest into things that have glaringly obvious needs. But when public health is working effectively and efficiently, you don't see those needs as publicly. It's usually when public health comes to the forefront of the public eye, which COVID-19 is a perfect example of, do you really see how under attack and archaic our public health infrastructure and spending actually is. So I'm just going to talk a little bit about kind of the past and how we started this initiative and how we started doing transformation work. So right here is our mission and our vision. So Healthier Mo, since its inception, has taken a grassroots approach to the public health system transformation. So our mission is Healthier Mo is a grassroots initiative focused on transforming Missouri's public health system into a stronger, more sustainable, culturally relevant, and responsive system that allows public health experts to better meet the challenges of Missouri's diverse communities and offer every Missourian the fair opportunity for health. So our vision is that every Missouri community will have a strong, stable, and lasting foundation for health and well-being that helps Missouri residents reach our full potential and ensures that together we can thrive. So this means that we've been very intentional about how we engage public health system stakeholders throughout our processes. And I'm not going to spend a lot of time discussing our past, but there have been some things that have been notable that I do want to share with you guys. So from the beginning, Healthier Missouri has been a multi-phase initiative. So this roadmap on your screen shows the highlights of our phase 1 and phase 2 work. We wrapped up phase 2 at the end of July, and phase 2 encompassed a lot of different projects. So I'll just highlight a couple of them, which would be some of our capacity assessment, the actual establishment of the future public health services model, and then our establishment of the professional organizations work group. And I'll kind of talk a little bit more about these things. So there is a national model for foundational public health services, and these are essentially the foundational services that every public health agency is required to provide. So health departments provide public health protections in a number of areas, which include preventing the spread of communicable disease, ensuring food, air, and water quality are safe, supporting maternal and child health, improving access to clinical care services, and preventing chronic disease and injury. In addition, public health departments provide local protections and services which are unique and individualized to their own community's needs. So the public health infrastructure here is at the top of this model, and it consists of what are called foundational capabilities. And these are cross-cutting skills and capacities that are needed to support basic public health protection and other programs and activities that are key to ensuring the community's health and achieving equitable outcomes. And then you have the public health programs, or the foundational areas, which are those boxes below. And those are basic public health topic-specific programs that are aimed at improving the health of the community affected by certain disease or public health threats. So examples include, but are not limited to, chronic disease prevention, community disease control, environmental public health, and maternal, child, and family health. So local protections and services unique to a community's needs are those determined to be of additional critical significance to a specific community's health and are supported by the public health infrastructure and programs. So this work is essential to a given community and cannot be visually depicted because it varies by jurisdiction. So examples of this include tobacco control programs, mobile dental units, and others. So this is kind of that national foundational public health services framework that a lot of states have been basing their systems transformation work off of. So these are the states that are currently doing transformation work using that foundational public health services model, or the FPHS model, to generate public health systems change. So all of these states are at various points, and they've all approached systems change differently. So just to kind of set the stage, transforming public health is a multi-year effort that requires commitment and buy-in from individuals who work within the system and others who are critical in achieving this far-reaching goal. So it's not something that can be accomplished over 1 year. And then there are state-specific foundational public health services frameworks. So that nationally developed FPHS framework reflects the consensus of public health and healthcare leaders across the country in the suite of skills, programs, and activities that must be available in every state and local health departments in order for the health system to work anywhere and for costs to be estimated. The FPHS delivery model, that is local public health department capacity and resources, historically have varied both within and between states across the country. So again, Missouri is the state that falls behind and is last in public health funding and spending per capita. So that's something to include when thinking about the delivery of your state-specific model. Then you have the public health system assessment, which is conducting an analysis of the gap between current investments and capacity and what's needed to implement the foundational public health services framework. And it provides that critical foundation for developing cost estimates and planning implementation strategies. And then, of course, financial and implementation strategies. So that's transitioning to a modernized public health system. And that requires carefully designed changes to the financial and operational practices within each state. Then you have accountability, and these are performance metrics that measure progress towards implementation of that FPHS framework. And they're also important accountability tools for policymakers, particularly if additional funding is allocated towards the governmental public health system. And then finally, you have legislation and impact. Legislation has been enacted in several states to guide transformation works. So for example, Washington actually created legislation that required the state and all local public health agencies to implement the foundational public health services model. Where here in Missouri, that type of top-down approach probably wouldn't work just based on the culture and ideologies that we have here in our state. And so in Missouri, we're using more of a grassroots approach, meaning bottom up, in order to generate that systems change. So one of the largest accomplishments during phase 2 was the development and adoption and publication of Missouri's foundational public health services model. So using that national model as the framework, we developed a bunch of different kind of work groups in order to figure out what were Missouri's specific programs and unique needs, and how can we tailor that national model to fit Missouri's communities. So this sets a minimum set of fundamental capabilities and areas of public health expertise that must be available in every community. So again, that model is based on the national model, but it includes a few elements that make it unique and tailored to Missouri's public health system, which includes the inclusion of a ring or lens that is dedicated to health equity and social determinants of health, something that is missing from that national framework. For those who are not yet familiar with the model, that blue outer ring are the foundational capabilities, and the inner pie-shaped pieces are the foundational areas. Public health infrastructure consists of the foundational capabilities, which are those cross-cutting skills and capacities needed to support basic public health protection and other programs and activities, which are key to ensuring the community's health and achieving equitable health outcomes. So public health programs, or those foundational areas, are those that are basic to public health and topic specific that are aimed at improving the health of the community. So examples, of course, are going to be your environmental public health, communicable disease control, chronic disease prevention, linkage to medical, behavioral, and community resources, injury prevention, and the maternal, child, and family health. Something to note is that that outer blue ring that includes assessment, surveillance, emergency preparedness and response, and all of those capabilities have been one of the instrumental pieces in order to address the inner pie-shaped pieces, or those areas. So through a lot of the research and through a lot of the work groups and the system stakeholders that we've brought together, those areas cannot be properly addressed and identified without building capacity in those capability areas, or that outer blue ring. So we also developed an interactive version of this model, which we refer to as the academic model. So the academic model can be found on our homepage. You can click on any given piece of the model and do a deep dive into its definition, capacities, and related resources. But more importantly, it addresses the problem of programmatic silos, which are common in both public health and in healthcare. So by allowing you to drag the various pieces of the model into alignment, you can see how those components interact or fit together. And then you can even see Missouri-specific case studies that will illustrate the intersection of these components. So I highly recommend that if you have the opportunity, is just to play with this interactive model and get more familiar with it. So just as an example, you can take that assessment and surveillance piece, or that capability, and you can drag it across to injury prevention, and you can see tools and resources and specific case studies that show within injury prevention how to do assessment and surveillance. So evidence suggests that many public health departments don't have the dedicated funding needed to build out and sustain their public health infrastructure. So without them, public health departments simply can't deliver the seamless, high quality protections that the public expects. To put this practically, health departments have to be ready 24/7 to serve their communities. And that requires access to a wide range of critical data sources, robust laboratory capacity, preparedness and policy planning capacity, and expert staff to leverage them in support of public health protections. Like all infrastructure, it tends to degrade over time without proactive maintenance and deliberate efforts to upgrade its capabilities and as communities grow and evolve. Just like a building relies on a strong foundation, we depend on foundational public health services to assure safe food, water, prevent injuries, stop the spread of disease, and improve health for our families, and to connect us with local resources. So this public health framework, together with quality education, safe and affordable housing, accessible healthcare, employment opportunities, all creates an environment in which all of us can live our healthiest lives and thrive. Another thing that Healthier Mo has done is bringing together various public health organizations into what is referred to as the professional organizations. All of the public health organizations in Missouri have the same goal, which is to improve the health and well-being of Missourians. So naturally, it makes sense to convene these organizations together so that way they have the opportunity to learn. Their mission is leading public health collective impact through advocacy, collaboration, communication, and workforce development. Members of this include all of the local public health agencies in the state, which there are 115, the state health department or the Department of Health and Senior Services, an accrediting organization, which is MICH or the Missouri Institute for Community Health, nurses, and all types of public health professionals. So just on this slide here, you can kind of see what their mission and vision is, and then you can see all of the different organizations that are a part of this. So while we were working to educate about the foundational public health services model, we began a public health system assessment using the model. So we called this the FPHS capacity assessment. And we teamed up with the wonderful folks at the Missouri Department of Health and Senior Services to combine our assessment survey with their infrastructure survey, which is given to local public health agencies every 2 years. So the survey data was collected between the spring and summer of 2020, which was right in the heat of the COVID-19 response. And it was a self-assessment of local public health agencies. It was a self-assessment of local public health agencies' current capacity to deliver the foundational public health services. So once the data was collected, it was compiled by our evaluator, Dr. Todd Daniel, and he completed an in-depth statistical analysis, which led to some very important conclusions about our current system capacity. So some of those important takeaways were that per capita funding is what drives capacity, that administrator experience and focus influence capacity, and capacity in capabilities is a strong predictor of capacity within the areas. So again, using that blue outer ring, if you're strong in those capabilities, you'll then be strong within those inner pie pieces or those areas. I won't go into further detail about the findings, but if you are interested in learning more about the full report and the summary report, all of that information is available on our website. The most importantly, though, in my mind, is just the incredible how incredibly helpful it is to have some of that quantitative data to back up much of what we already know anecdotally, and that can help with future public health advocacy efforts. Dr. Daniel also produced a shorter report that examined the relationship between FPHS capacity and accreditation status. A few of his findings, again, the full report is available on the website, but a few of his findings include that accreditation is rare. Only 18.9% of local public health agencies in Missouri have achieved some form of accreditation. And in order to fully assure the foundational public health services model, you would need 44.1% of local public health agencies to assure that minimum set of foundational capabilities and the public health areas of expertise. 31.5% are not yet able to assure the full model. So that's quite a large percentage that aren't able to. Accreditation is what predicts capacity. So accredited local public health agencies are 2.7 times more likely to fully assure the foundational public health services model than unaccredited agencies. So phase 2 wrapped up in July. And so moving forward, we wanted to make sure that we were still traveling a transformation path and that it was based on the system needs. So therefore, we did some further data collection. So we collected data both in 2018 and 2021 to compare the top reasons for transformation. So here are the results from the 2018 data that we had collected. So the top 3 reasons for wanting transformation are stable and increased funding, a unified voice, which is focused on priority issues, and then higher quality and more consistent operations. So these 3 topics were what we addressed in the phase 3 plan. So once COVID-19 ramped up and the context of our public health system and healthcare system began to change, we knew that we needed to do another check-in and see if those same system stakeholders felt that other things needed to be prioritized in comparison to 2018. Because I think, as we all know, COVID-19 has brought forth a lot of issues that maybe we weren't presently aware of before. So what you see here are the results of that survey. There's nothing surprising here given the circumstances. The top 3 reasons are stable and increased funding, higher quality and more consistent operations, and a unified voice focused on priority issues. So essentially those top 3 reasons stayed the same for systems transformation. But something to note is that coordination across agencies dropped from 3rd to 5th. And so that information helped guide us as we navigated finding our role during the heat of the pandemic. So part of the data collection process was also capturing public health stories. I think we all know that as humans, one of the best ways that we communicate with others is through narrative form. So stories are something we could learn from, but also could share the value of public health. So Jackie McReynolds, our communications coordinator, captured video stories and worked with an organization called Humans of St. Louis to collect written stories as well. So I want to share a clip from one of these stories that highlights Kelly Vollmer, who is the director of the Jefferson County Health Department close to St. Louis. So Kelly and her team have seen great success in terms of operationalizing the foundational public health services model within their department. And after speaking with her, we knew that we would need that information to be the next step forward with the model and creating tools to help with implementation processes. So hopefully you guys will be able to hear this, and please let me know if you cannot. I apologize, technology is always fun. One moment. Okay, so it looks like it's not going to work for us, which on a Friday afternoon, that sounds pretty much like what technology would do. So I apologize about that. But this video is also available on our website. So if you guys do want to look at that, you can have the opportunity to take a look at that later. So our first and exciting step towards creating these implementation tools is the capacity assessment toolkit. So earlier this fall, this personalized toolkit was sent out to each local public health agency that completed the capacity assessment. So we wanted to share their capacity assessment data back with them in a format that we hope will be useful as they complete their own assessment and planning work. So essentially what this toolkit does is it contains an overview of the capacity assessment findings that's individualized to their agency, which includes a comparison of their data with the region and the state. It also includes some prompts and questions to aid them in beginning to think through how they can apply the foundational public health services model to their current work and to begin addressing some of their local capacity gaps. This toolkit has not yet rolled out as it is currently on pause. We will be rolling it out in the spring to every single local public health agency because we are going to be including some health equity tools and resources along with it. We are also pilot testing a foundational public health services curriculum for university settings, educating up and coming public health professionals about that foundational public health services model. It's shared, and we're also going to be sharing public health resources through our monthly email updates and social media posts. We participate in the 21C learning community, which is through a national network of states that are currently doing that public health systems transformation work. So from that previous slide where you saw all of the states that are involved, we also have a network called the 21C learning community where we can learn from each other's processes in order to best address our own system transformation work. And we also serve on various work groups that are tied to transformation efforts, which include workforce development pipelines, workforce development groups, advocacy work groups, professional organization boards, different things like that. So looking towards our future, the next steps in operationalizing the model include further education about the model. So we're working with Dr. Kristen Wilson and her team at the Heartland Center, located at St. Louis University, to develop a foundational public health services training portal website. So this essentially is going to be kind of like a one-stop shop for vetted trainings about the various elements of the FPHS model, as well as health equity. This page is still in the development process, but this is what the current landing page of that looks like. So next, we recognize that COVID-19 has generated a very distinct window of opportunity to strengthen health equity policies, practices, and to address those social determinants of health across the foundational areas and foundational capabilities. So applying health equity policies and practices is just one more way that we can increase efficiency and effectiveness of the foundational capabilities and foundational areas. So I'm excited to share that the next steps for prioritizing health equity work in Missouri includes bringing on board a team of health equity subject matter experts called Consilience Group. So Consilience Group has experience in both urban and rural public health equity, including deep work with several local public health agencies in the Missouri Boot Heel Babies and Families program, and work with the cities of St. Louis and Kansas City. So they're a mission-driven systems transformation firm committed to the physical, social, and economic well-being of all people and communities. They work within and across sectors, systems, and organizations in order to align and integrate policy and practices for equitable, people-centered services. So we are working with them on developing a health equity curriculum for trainings of our public health professionals, and our health equity work will also be included in all of those workbooks that will be going out to each local public health agency, including tools and resources for achieving the foundational public health services through a health equity lens. So you may have seen this before, but this is one of my favorite graphics. It just goes to show the differences between equality and equity. So not everyone requires the same services, and you're probably familiar with this in clinical care. The same goes for public health services. So how do we work together to ensure that every Missourian has a fair opportunity for health? Equity is at the heart of the foundational public health services model, and equity and equality are not the same thing. So this bike graphic shows that we can all have equal access to bikes, but that doesn't mean that we can all ride our bikes, if at all. So equity is recognizing that the tools we must offer must meet the needs of the individuals being served. And equity is a key component of that foundational public health services model. So health equity is a lens that all services, interventions, and programs should be implemented and viewed through. Just like how in clinical medicine, you have to get to know and explicitly understand the needs of your patients, in public health, we have to understand the specific needs and gaps within our own communities. As future healthcare professionals, you probably know that health inequities and health disparities are vital to address in order to improve health outcomes. This includes in addressing the social determinants of health, which are influencing our health more than our own genetics. So these are things like socioeconomic status, housing, education, neighborhood safety, adverse childhood experiences, access and affordability of healthy and nutritious foods. A lot of hospitals and healthcare systems have started to asking questions and screening for these social determinants of health as a way to improve quality of healthcare and ensure that they're meeting the needs of their patients. And that approach is borrowed from public health. In some communities, the services that a health department provides are the only form of healthcare people have. In a lot of communities, especially in rural Missouri, where some counties don't even have a primary care physician, public health acts as that social safety net. So they help individuals get enrolled in health insurance, become eligible for SNAP benefits, provide immunizations, assist families and individuals with getting fresh produce, among many other services. So these are some reasons why investing in public health is critical and how it can impact all of you guys as future healthcare professionals. So the goal of public health is to improve the health and well-being of our communities, just like in clinical medicine, where the goal is to improve the health and well-being of your patients. A great example of this and the overlap between public health and clinical medicine is immunizations. So immunizations are one of public health's greatest achievements by extending the life expectancy by 25 years. Having a strong public health system that uses the foundational public health services model can ensure that minimum services of providing vaccines to children can save up to $11 in healthcare costs down the line. While the foundational public health services model has those minimum services that LPHAs are required to provide, there are a lot of health departments that also provide other community services. So just as an example here, St. Louis has a pretty robust prescription drug monitoring program, or a PDMP, where they assist the healthcare system to ensure that all their providers have access to the PDMP, and it removes the burden of registration from each individual healthcare provider. Also, while not one of the minimum foundational public health services, St. Louis Health Department is also in charge of animal control for the city. Animal control probably sounds weird. It's like that's not really a public health issue, but it is. If you're familiar with One Health approaches, it fits right in. As a part of this, they ensure the health and safety of residents through enforcement of pet-related ordinances and the promotion of responsible pet ownership. So they also have a dog bite prevention program, which assists in the prevention of rabies. One of the things that a lot of health departments do to improve maternal and child health is through a WIC program. WIC stands for Women, Children, and Infants. The program is designed to improve the nutritional health of low-income pregnant women, breastfeeding moms, infants, and children, all the way up till the age of 5, with the goal of improving the overall health of families. WIC also provides nutrition education, breastfeeding education and support, as well as a supplemental food package and referrals to healthcare providers and local agencies. Having a WIC program at a health department is effective and helps to reduce premature births, reduce low and very low birth weight in babies, reduce fetal and infant deaths, increase prenatal care earlier in pregnancy, increase diet quality, and increase access to regular health care. Also, a few of the local public health agencies still have home health programs. So Montgomery County here in Missouri, their program is actually award-winning. And it would be good for doctors to be aware that local public health agencies are an option and might even be less expensive than a private provider. So thinking about some of those private institutions for home health care. The patient can choose their own home health agency, but the doctor could ask them if they'd like to use their local health department if a program is offered by that local public health agency. Another way that LPHAs or local public health agencies and clinicians can work together is through the management of various chronic diseases. So one thing I hear often from local public health agencies is that they wish doctors would refer their patients with prediabetes, new diabetes, hypertension, and others to the local public health agency for health education on choosing a healthier lifestyle and in some cases monitoring. So doctors could work with their local public health agencies to develop a formal partnership where the doctors could write an actual prescription for the patient to go to the health department for health education. And that helps take the burden off of some of the healthcare system as well. Most of the time, doctors are working in secondary and tertiary care, and public health's role really belongs in primary prevention. So this means that if we really invest in public health and we really transform our system into a 21st century modernized public health infrastructure, we're helping to address and prevent a lot of the burden that gets put onto doctors in the healthcare system. So long story short, public health and clinical medicines are two sides of a very important coin. And you need both of those in order to actually improve health outcomes. So just in summary here, I do want to re-emphasize the grassroots approach that Healthier Missouri has done with all of this work. So it takes a lot longer than top-down approaches, like, for example, Washington's approach. But here in Missouri, we have been really good about convening all of the appropriate stakeholders, ensuring that all of the appropriate people are represented and brought to the table, that all voices are heard, and that we're really taking the time to develop the system from the bottom up so that everybody's included and that all capacities are risen. So if you want to stay informed, you can sign up for our email newsletter, which actually just went out today, this morning at 8 a.m. You can follow our initiative on social media. You can review resources on the website. You can connect to us by adding your name to a map. And then you can talk about Healthier Mo with your partners and stakeholders. And we also have what's called the BOSE storytelling portal. And so I think a lot of you guys here as future healthcare professionals and current healthcare professionals work with a lot of people individually, and you have your own stories and your own narratives to be sharing. And so that's an opportunity for you to share those stories through our portal so that way we're bringing awareness to all of the issues that are occurring. Also, you can engage with us. You can amplify social media content. You can participate on an equity design team. You can operationalize our model through your own organizations and share your expertise through surveys and polls. So at this point, I will go ahead and open up the floor to any questions because I know that I ran through a lot. And again, I apologize about the video. But here's my contact information. If you don't feel comfortable answering questions in this public forum, you can go ahead and contact me, or if you want to get involved, you can contact me that way. But I will go ahead and stop sharing and open it up for questions.
Thank you so much, Emily. Does anyone have any questions today? Feel free to unmute or put those in the chat.
Is the PowerPoint available for us to review?
We can do that. I can go ahead, we can make sure that that's available. It is a very large file. So we can go ahead and get that ready, and we can send that to Marcy, and then she can send that out to everybody.
Okay, thank you.
Marcy has also included the link to the evaluation and the program ID number. So if you guys want to take a few minutes to go ahead and complete that evaluation, that would be great. And if no one has any questions, we'll go ahead and cut this short. Appreciate everyone today. And Emily, thank you so much for taking time with us and sharing about public health services and how we're going to improve those in the future. Happy holidays, everyone. Hope you guys have a great break, and we'll see you back in January.